Hopefully you can hear me on this one. My microphone died while I recorded this past lecture last week. So I am re-recording it for you to make sure that this time that the audio doesn't cut out 18 minutes in. I'm a little frustrated, as you can kind of tell, but I want to push through and make sure that you get the lecture that you deserve. So for this lecture, we're starting to talk about affective disorders. Why did it go all the way back? All right, let's try that again. Okay, so what you are looking at here is a painting by Vincent van Gogh. And for those of you who may not have as much training in art history or in humanities, it's pretty well documented that Vincent van Gogh might have potentially suffered from bipolar disorder. So in this lecture, we're going to focus on mood disorders or what are termed affective disorders. Um, so one of the things that you'll kind of notice when you're getting these lectures is, at least when I'm talking about the diagnostic criteria, I utilize both the DSM-4 and the DSM-5. The DSM-5 is the current psychiatric manual for diagnosing and classifying different types of disorders. There is some disagreement about whether or not the DSM-5 is an advantage over DSM-4. The DSM-4 has quite a few defenders as well. And since 5 kind of builds on 4, I thought it was kind of worth bringing up both the DSM-4 and the DSM-5 and how things have changed. So we're going to talk about these different types of mood disorders. So we have major depressive disorder, or what you might know as major depression. We have dysthymia, which is basically a low grade sort of depression. It is typically less severe than a major depressive episode. And rather than being something that occurs over a period of several months, somebody with dysthymia is always going to chronically have this low grade depression. It's part of the reason that it's now referred to as persistent depressive disorder. So then we have bipolar disorder. Bipolar disorder comes in two different forms. There's bipolar type 1 and there's bipolar type 2. Bipolar 1 will include manic episodes and depressive episodes. Mania can actually include both paranoia and hallucinations and have psychotic features like schizophrenia. Misdiagnosis is pretty common, or at the very least, it's not rare. Bipolar type 2 is like bipolar type 1, except the manic episodes are typically not as severe. So the difference between type 1 and type 2 is a matter of severity. Then rapid cycling is something that can absolutely happen with bipolar disorder. Rapid cycling is when you have 4 periods of depression and mania, basically alternating within the period of a year. We also have seasonal affective disorder, which we will talk about more. And then we also have mood disorders that are due to a variety of different circumstances, such as hormonal changes during postpartum periods, general medical disorders, substance-related depression. So substance-related mood disorder is typically diagnosed when a clinician believes that a drug or some other chemical substance or withdrawal from that substance actually causes symptoms that are suggestive of these types of mood disorders. So we're going to start by talking about major depressive disorder and unipolar depression. So it is 2 times as common in women as it is in men. Why that is not clear. At least one big factor, though not the only one, is a lack of diagnosis in men. Typically, men feel a bit of a stigma admitting weaknesses and may not necessarily get the help they need. Additionally, we do know that for men, that depression may potentially manifest rather than emotion-based symptoms. It sometimes manifests as bodily pain. So it's generally in the United States, up to 17% of people in the United States will experience depression at some point in their lives. About 21 to 24% of women, estimates between about 12 to 15% of men will experience. A peak onset tends to occur between the ages of 30 and 40. It has a common comorbidity. This means that it very likely occurs with other illnesses. Depression is very commonly comorbid with other illnesses. That can include physical illnesses such as cancer, stroke, chronic illness. It can also occur with different types of mental disorders such as anxiety or developmental disorders or things like that, like possibly ADHD or autism spectrum disorder. Of people that are diagnosed with major depressive disorder or unipolar depression, about 15% attempt suicide. Now, bipolar disorder is far less common. It occurs in about 1% of people in the United States. In contrast to disorders like depression or anxiety, it's actually equally distributed between the genders. And that kind of suggests that there is a very strong genetic link there, and that it's less likely to be due to something like socialization. The peak onset tends to occur in the late teens and the early 20s. And of those who are diagnosed with bipolar disorder, about 30% attempt suicide. So, what are the diagnostic criteria for a major depressive episode? So, this will be true for people that simply suffer from depression. This will also be true for people that are suffering from bipolar disorder. So, here are the criteria from the DSM 4. You have to have 5 or more of these criteria within the past 2 weeks, and they should be a majority of that time. So, depressed mood, loss of interest in pleasure. So, if you no longer enjoy doing the things that you like to do, you may be experiencing a depressive episode, weight gain or weight loss, insomnia or hypersomnia, so sleeping too much or not sleeping enough, fatigue, feelings of guilt or worthlessness, diminished ability to think or concentrate, kind of like a brain fog, and recurrent thoughts of death. Now, as of May 2013, with the publication of the DSM 5, thankfully the criteria for depression hasn't really changed all that much. One of the things that's kind of interesting is that they did remove what is referred to as the bereavement exclusion. So, if you were diagnosed, you could not be diagnosed with depression until you had been grieving the loss of a friend or a loved one for about 2 months. Now we kind of work from the idea that you can be grieving and experiencing depression at the same time. And additionally, there were additional specifiers added for potential suicidality. Who's going to be more of a risk? Who might be less of a risk? Now, what about manic episodes? So, for bipolar disorder, you have to have periods of depression and you have to have periods of mania. What do we mean by mania? So, as of the DSM 4, a manic episode was defined as a distinct period of an abnormally elevated mood. So, that abnormally elevated mood is critical. So, somebody who's generally pretty upbeat and high energy, they may not necessarily be having a manic episode because that's what is normal for them. But if you're somebody whose energy levels are much more calm, and all of a sudden you go through a period where you have a lot of energy and really elevated mood beyond what you'd normally experience, it might be a manic episode. So you're supposed to have 3 or more of the following within this period. Inflated self esteem or grandiosity, possibly to the point of delusions of grandeur, a decreased need for sleep, increased talkativeness, racing thoughts, distractibility, increased goal directed activity, and excessive risky pleasure seeking. So people may spend a lot of money, they may go on some kind of binge like partying or risky sex or pathological gambling. These manic episodes are experienced by many people as a high. Generally, people tend to like their manic episodes. They feel really productive, they feel good, they can get a lot of things done. Now, I do want to mention that because of the way that a manic episode is, that it may potentially look like other types of disorders. So, as I mentioned, delusions of grandeur can occur, but it's different from schizophrenia in that even though there are racing thoughts in a manic episode, they're not necessarily as disorganized as we might see in schizophrenia. Additionally, this risk taking behavior does have some overlap with acquired sociopathy. We did notice in our last week's lectures that people with acquired sociopathy tend to engage in risky behaviors. But people with damage to the orbitofrontal cortex don't typically have racing thoughts, and they don't have that general overall higher energy level. So there are some important differences, even though there are some similarities as well. So, as of the DSM-5, how have these changed? Generally, there's been a greater emphasis on what's going on during the manic episodes. So, what kind of activity is going on, as well as the energy levels, and less of an emphasis on mood on its own. So, I think that's pretty important. So, bipolar disorder typically will have one or more manic episodes, usually with one or more depressive episodes. Bipolar episodes last several months, so these cycles happen maybe once or twice per year. You can have rapid cycling, but that just means that the depressive episodes and the manic episodes will be shorter as you will have more of these cycles throughout the year. Generally, the manic episodes do tend to be shorter than the depressive episodes. And so, one of the things that I think is kind of interesting is that if you look at a manic episode, where is all of this energy coming from? And there does seem to be a bit of a link to the brain. So, what you're looking at here is a PET scan of a brain of somebody with bipolar disorder during depressive episodes and manic episodes. And so, again, with a PET scan, remember that we're looking at the metabolic activity of glucose. The idea being that more active areas tend to metabolize glucose more quickly. So, if you're seeing a lot of yellow, orange, and red, that means areas of higher activity. If you see cooler colors like blue and green, or even purple, that means areas of lower activity. And so what you can kind of see is that relative to the brain in a depressive state, there's really not a lot of activity. However, manic episodes are very highly marked by enhanced glucose metabolism. And so, what this means is that there is this enhanced activity in manic episodes that we typically do not see in depressive episodes. Now, this enhanced activity is not really well understood. It could potentially be related to dopamine. Now, one critical question that often tends to come up in general, major depression is one of the more common psychological disorders that people will experience. It is currently not the most common. I believe anxiety disorders are far more diagnosed, but depression is certainly up there. Now, despite the fact that we are becoming more and more aware of mental illness and we're trying to fight that stigma, groups like the National Institute of Mental Health and the Food and Drug Administration typically do report that major depressive disorder is probably underdiagnosed. And we're partially sure why, but we're not 100% sure why. First of all, oftentimes I know there have been times where I've been struggling with my mood, and based on the fact that depression is basically based off of a 2 week period, I'm curious as to whether there were points in my life where, yeah, if I had gone in at the right time, I probably would have been diagnosed with depression. Um, but I have a feeling I didn't go because I thought it was just because I was stressed. And once the stress was over, I would be okay. So oftentimes we'll tend to find that people don't seek help because they think it's just related to work stress. And if that work stress goes away, they'll feel better. Also, especially in an individualistic culture such as ours, and one that really emphasizes having a strong work ethic and trying hard, there's this notion that if you're depressed, you're not trying hard enough. You didn't try to fight hard enough. Or that you might have some secondary motive for sharing and your feelings with others and feeling bad. You're just looking for sympathy. You're just looking for attention. So that's certainly part of it. There's a huge stigma. I can even tell you when I was dealing with my anxiety disorder, there was a part of me that felt like I hadn't tried hard enough. Despite the fact that if any of you had told me that you were struggling with something like that, I would never have said such a thing, but it's hard not to think that in the moment. The symptoms of depression are not always super obvious. There's no lab test for this, and everybody's going to manifest depressive symptoms in different ways. Now, something like mania, though, well, that's a little harder to dismiss because change is obvious and it's right in front of you, and you can't really mask those energy levels. So, just something to think about. So, let's go on and talk about some of the different causes of these affective disorders. And so, of course, if we're going to talk about psychological phenomena, we do have to talk about genetics. And as I mentioned, bipolar disorder has a very strong genetic link. So, when researchers have looked at monozygotic twins, that is, identical twins who come from the same egg, they actually find that there is a 69% concordance rate. That means that if one twin has bipolar disorder, there is a 69% chance the other twin will have it as well. And this is true whether the twins are raised together or the twins are raised apart. Because monozygotic twins share 100% of their DNA with each other, there is a very strong genetic link. With dizygotic twins that share about 50% of each other's DNA, there's about a 13% concordance. Generally, bipolar disorder, you have a 25% chance of developing it if a parent has had a mood disorder, especially if bipolar. If you have a sibling that has bipolar disorder, you are estimates range between 8 times and 18 times more likely to get it. So it's a pretty strong genetic link for bipolar. Major depression, on the other hand, does not have as strong of a link. With major depression, you are 1 to 3 times more likely to develop it if your parent has developed it. So these do run in families, but at least with depression, we also have to consider internal responses, your own personal psychology, and your environment. Now, there is no depression gene. Numerous genes might actually be responsible. One that we will talk about a little bit more in the next lecture is chromosome 17, which helps code for the serotonin reuptake transporter. And generally, we find that you're more likely to have recurring episodes if they are genetically linked. What about some environmental and biological triggers? You can have a genetic predisposition to a mood disorder, but one of the things that we find is that genes are basically only designed to work in a very specific sort of environment. They have to have the right kind of trigger to turn on that protein production. So genes can only express themselves in certain environments. So if you don't, if even if you're predisposed to developing a mood disorder, you may never develop one because of your environment. But here are some pretty common triggers. One of the biggest ones is, of course, the death of a friend or a family member or a loved one. Bereavement can be a very powerful environmental cue. Traumatic events such as accidents, interpersonal problems, a relationship breakup, divorce, job loss, etc. Hormonal imbalances such as childbirth, menopause, or aging. Postpartum depression is one of those potential variants. This tends to occur after childbirth for a period of several months, and it's partially due to the changes in hormones after pregnancy, and also due to the fact that with a newborn child, you are probably not getting the amount of sleep that you would normally need. One of the other things that we find is that menopause is also a potential trigger. Usually, with menopause in women, the amount of estrogen circulating drops. And estrogen modulates the level of serotonin in the body. And we find that this happens with men too. Testosterone also modulates serotonin. And so changes in hormones can lead to mood disorders. This hormonal factor may explain why bipolar disorder is often diagnosed in the post teen years. There are massive changes in sex steroids like estrogen and testosterone during those times. As we'll soon talk about, disordered sleep can also make depression or other mood disorders more likely, and winter. So why does winter disrupt mood? When you are in winter, you get less exposure to ultraviolet light, and generally, ultraviolet light is really critical for vitamin D synthesis. Vitamin D is in a variety of different foods like dairy and fish, and it's only going to be synthesized by the skin when you're exposed to UV light. And that helps facilitate serotonin synthesis. So it's often recommended that if you live around a certain point of, I believe, latitude, you should probably be taking a vitamin D supplement because, especially in the wintertime when the sun is out less often and there's, yes, less UV light to be exposed to, you're going to run the risk of not feeling too happy. And we'll talk more about seasonal affective disorder in a second. The winter is really critical. You can see that even though there is some light here, it's definitely not the level of sunlight that we think of when we think of a nice spring or summer day. That's especially true after time changes. So seasonal affective disorder, getting the winter blues is definitely a thing that happens to a lot of different people. Thanks to daylight saving time in the fall, the sun goes down at about 5 o'clock, or in some cases even earlier. It gets cold outside. You're spending less time outside. So everybody gets kind of sad during winter, especially after the holidays. But if the symptoms are severe enough, they may warrant a diagnosis of seasonal affective disorder. This can be especially common in areas like the Arctic Circle and Scandinavia, areas like Finland, Canada, Alaska. And it's because we get these disrupted light dark cycles. So, low sunlight is going to lead to less serotonin production, less vitamin D production, and that's going to be really critical for serotonin production and synthesis. Additionally, darkness triggers the release of hormones like melatonin that help us sleep. So if there's too much darkness, or in certain places in the Arctic Circle in the winter, if there's not enough darkness, that actually changes the cycling of melatonin. So what's kind of interesting is that compared to major depressive disorder, seasonal affective disorder has some very unique symptoms. First of all, there is an intense hunger and a craving for carbohydrates. Carbs typically will lead to increased insulin secretion from the pancreas, and it also helps produce more tryptophan, which is a precursor of serotonin. So it's possible that people might be self medicating. Um, there can also be significant winter weight gain, and you may see sleeping more than usual. So, depression is often associated with a reduced appetite, though not always. Seasonal affective disorder is a little bit more atypical, as you can see. To be diagnosed, you must not have other depressive episodes that are not linked to seasonal fluctuations. So this has to specifically only happen when the seasons change. So how do we treat it? Well, one of the things that we can do is phototherapy, so light therapy. People who are struggling with seasonal affective disorder may be given a light box like the kind you see here that shows full spectrums of light, including ultraviolet light, and they have to sit in front of this for about 60 minutes or more per day. SSRIs, selective serotonin reuptake inhibitors, which are pretty common antidepressants, may also be recommended. So now let's talk about the role that disordered sleep plays with depression. So, one of the things that we are going to find is that one important thing to know is that when you are in REM sleep, so rapid eye movement sleep, it's a special stage of sleep where your brain is incredibly active and you're probably dreaming during this time. This is a period of time where monoamine release is actually blocked. So you are not releasing dopamine, you are not releasing serotonin, and you're not releasing norepinephrine. So REM sleep is a really critical part of sleep. And this blockade of monoamines is really, really critical. This blockade is normal. It helps resensitize these neurotransmitter systems and receptors so that they don't become overstimulated. So you're basically giving them a chance to rest. Now, how does all of this get knocked off kilter when you're struggling with depression and you might be feeling insomnia? Well, it's one of those cases where we're not really sure what comes first. In the case of depression, that can lead to insomnia, but it's also true that insomnia can lead to depression. Now, insomnia can put one under psychological stress. There is nothing more stressful than laying down, trying to sleep, tossing and turning, and then looking at your clock, realizing how late it is, and getting yourself worked up because you can't sleep. So when you're stressed, guess what system's going to get involved? Your HPA axis. So your HPA axis is going to get stimulated by this stress, and you're going to have chronic sympathetic activation. So you're going to get release of norepinephrine, and you're going to get release of glucocorticoids. And we know when you're stressed and you try to sleep, that norepinephrine is going to produce a very fragmented, shallow sleep. And you're probably not going to spend as much time as you need in REM initially. And you won't get that deep sleep that you need. And because you didn't sleep very well, the next time you try to sleep, your brain is going to spend more time trying to put you in REM sleep, which means less monoamines because of that blockade, and then an increase in depression. Low serotonin is linked to depression. Low dopamine and low norepinephrine may relate to sluggishness and the low energy that you might feel. So let's compare somebody who is not depressed and the sleep cycles with somebody who is depressed. So typically early on throughout the night in a normal sleep cycle, you very briefly go through all four stages of sleep. Three and four are considered deep sleep. And then once you've cycled through those four stages, you cycle back up to light sleep and you go into REM sleep. Now, as you sleep throughout the night, you spend less time, as you can see here, in these deeper sleep stages, and you spend more and more time in REM sleep. These arrows, by the way, are different periods of waking. So this person has only woken up once, and they've already had several periods of REM sleep and several periods of deep sleep. Now, somebody who's depressed and probably struggling with insomnia, they're going to not really spend a lot of time in deep sleep, which is kind of critical. They're going to spend more time waking up, and notice that they're trying to get into REM sleep more and more and more. And one of the things that we know is that if your REM sleep is interrupted, we have what's called REM rebound. So the next time you fall asleep, you're going to enter REM sleep much more quickly. So, for example, take a look at this stage of sleep. They're in it for about the better period of an hour before going into REM. This person is maybe in it for 15 minutes before they go into REM sleep. So, because of that, your brain is trying to spend more time in that REM sleep, which means you're not getting the monoamines released. So how do we fix it? Well, you could do a partial or complete sleep deprivation. This ideally reduces the amount of REM sleep. Partial tends to take longer than complete deprivation to work. And about 60% do report an immediate recovery. We can give people melatonin to help induce sleep, or we can use antidepressants. So now we're going to start by talking about some of the biology of these affective disorders. So just a reminder, when we talk about these monoamines, remember that we have a few different types. So we have our catecholamines, which we call them as such because they're made up of a catechol ring and an amine group. And that includes dopamine, epinephrine, and norepinephrine. And then we have our indolamine, which is serotonin. Now, by and large, we're going to find that norepinephrine and to a greater extent serotonin are largely going to be the primary targets of antidepressants. Now, these monoamines do not cross the blood-brain barrier. The fact that they don't means that we're going to, if we want to enhance serotonin or if we want to enhance norepinephrine, we either have to use a precursor or we have to find some other way to enhance that release without actually giving somebody a pill of serotonin. So we can't really give somebody with a low level of serotonin a serotonin pill. We've got to find another way. So why do we believe that the monoamines are involved with mood disorders? We largely know about this because of reserpine. So our current understanding of the pharmacology of depression really comes from the Indian snakefruit plant, Rauwolfia serpentina, better known to you as reserpine. Now, as a reminder, reserpine is used to treat snakebite. It's also used to treat hypertension, which can happen because of overactive norepinephrine, or psychosis, which is due to overactive dopamine. Reserpine basically prevents monoamines from being released by blocking their storage into vesicles. So reserpine inhibits norepinephrine release, it inhibits dopamine release, and it inhibits serotonin. So it was used up until the 1950s to treat hypertension and psychosis, but researchers actually found that some of the side effects of this plant included tranquility and depression in about 15% of people. So this side effect led to what we call the monoamine hypothesis of depression. This is by and large the most accepted view of how depression happens at a neurotransmitter level. The link between the monoamines and the depression resulted from the treatment of hypertension with reserpine. And it was believed that the depression that resulted was caused by low monoamine activity, in particular serotonin, and to a lesser extent, norepinephrine. The reason for this is that when researchers gave dopamine agonists that enhanced the release of dopamine, like cocaine and amphetamines, it did not treat the depression. So when you prevent the monoamines from being stored into vesicles, they can't get released. And so that may result in a depression. And as such, we've spent a lot of time focusing on serotonin. The problem with this, though, and we'll kind of get to why the low serotonin equals depression hypothesis may not be correct. But let's talk about the effects that both serotonin and norepinephrine might have on depression. Now, we know that when norepinephrine is underactive, people tend to report low energy, a lack of interest and attention. And that's because norepinephrine is really critical for alertness, attention, and that sympathetic nervous system activity. Now, if serotonin is underactive, people experience things like despair, melancholy, guilt, anxiety, and irritability. Kind of taken together, this may look like a depressive episode. And generally, people will have differing combinations of these symptoms. Now, on the other hand, manic episodes cannot be explained by this hypoactivity. Is it because of hyperactive dopamine? Is it because of hyperactive acetylcholine? We don't really know. So let's get back to this idea that depression is due to low serotonin. This is something you tend to hear a lot about. And at least from a pharmacological perspective, when we talk about depression treatments, we're usually talking about enhancing the release of serotonin. But one of the things that's kind of interesting is that depending on the study, not everybody finds low serotonin levels in people or animals with depression. In some cases, researchers have reported that the serotonin levels might actually be high or hyperactive. Now, probably one of the biggest knocks against the low serotonin theory of depression is that we have selective serotonin reuptake inhibitors. They are typically the first type of antidepressant that will be prescribed to somebody. And generally, maybe only about 30% of people report feeling better from these. So the benefits of selective serotonin reuptake inhibitors are pretty modest. So whatever the biological effect with depression is, it may not be hypoactive serotonin. So we'll talk some more about some of these different biological issues, genetic effects, and treatments for depression next time.